Welcome in, everybody. Dr. Tim Brown, you're listening to Farmcast for the Community. We are back for 2023. I want to tell you guys that this month I'm going to be talking with Dr. Harvey about obesity and how to manage it, which is a hot topic. But also in March, I have Dr. Joey Baker coming on to talk about HPV, which is the virus that can cause cervical cancer, anal cancer, and other types of cancer, and the vaccines that are out there to prevent it. So Dr. Baker is going to walk us through that in the month of March, talk about how we can prevent cancers by stopping this nasty virus. And she's going to walk us through what's available and also who should be getting it. But before we get to March, we have February. As I mentioned, I have Dr. Keisha Harvey on board. I have to tell you guys, I had the privilege back at the end of last year of listening to Dr. Harvey speak at a big conference on obesity management. And after I heard her speak, I said to myself, I really need to reach out to this person and get her to come on this podcast, because her approach to her patients and how she works with them to help them with their management of their weight is lovely and wonderful. And it's not about anything other than just helping patients out. And so I wanted her on board today. Now, she's a family medicine physician. She's certified in lifestyle and obesity medicine. She's in private practice in, is it Bogalusa? Did I say it correct?
Bogalusa, yes.
Love that. Bogalusa, Louisiana. She also takes care of all the other conditions associated with family medicine and all the family members that you may think of, from babies all the way to your grandparents and great-grandparents. But her favorite condition and favorite thing to talk about with her patients is helping them with their weight. Welcome in, Dr. Harvey. Thanks for joining me.
Thank you for having me. I'm so excited to share this topic with you. And I was just thinking, we're talking about obesity in the month of love. So happy future Valentine's Day or past Valentine's Day to everyone.
Lovely. I agree. And that's where we start. We need to love ourselves a bit, because this journey for obesity, I have to admit, I have gone through ups and downs of weight. I have worked out. I've been an athlete. I've done this, done that. But no matter what you do, there are just times I think I need to lose weight to feel either good about myself, or because I'm getting ready to go to my annual appointment with my family medicine doc, who's going to tell me that I'm overweight or my BMI is too much. How do I know if I qualify for the word obesity just versus being overweight? Like, are there criteria for that?
There are criteria, but I also want to touch on something you said. You
Yeah.
said, I want to lose some weight to feel good about myself. And I think just initially just feeling good about yourself is something that can actually help you lose weight. Because when we feel good about ourselves, we want to treat ourselves better. And as someone who struggles with having obesity and having overweight, one day I was laying in bed and I was like, God, I'm supposed to be educating people how to be healthier and leaner, and here I am struggling. And then I had, to me, what was a download. And it was like, okay, this is the body that helped me birth 2 children. And this is the body that gets me up every day and make sure I can work and feed my family. I rarely get sick. And so, just the first step is when you have to be okay, or not okay, you have to love yourself and appreciate yourself for who you are. And because of that, work to pursue better health for yourself. But back to the question you asked me, to be classified as obese, you have to have a BMI greater than 30. And then we also break it down to classes. The class 1 is BMI 30 to 34.9, then class 2 is BMI greater than 35, and then class 3 is BMI greater than 40. And now we're talking about something called super obesity. We haven't coined a better term for it, but it's also having a BMI greater than 50. If you are someone who has overweight or is classified as overweight, what is helpful is actually doing a waist circumference, because if you deposit more adipose tissue around your midsection, it still places you at a higher risk for diabetes, high cholesterol, high blood pressure. And so if you have a waist circumference greater than 35 inches for men, for women, and greater than 40 inches for men, that places you at a higher risk. And Something we're also doing for another measurement, because we are in the time where we love numbers and charts and whatever.
Yes, we do.
We're doing the waist to hip ratio. So if you're a male and you have a waist to hip ratio greater than 0.9, and if you're a female and it's greater than 0.85, you could be categorized as obese.
It's interesting. So BMI is like body mass index, guys. And I have to tell you, every year I have to go and get this biometric screening for my insurance. And I had to do it, and I had to do it yesterday. And I thought, how timely is this? And to get my BMI, I have to hold what looks like a controller up on a video game with my hands, and it gives basically my fat content of my body. I just feel like, oh my gosh, I'm like so conscious about what that's going to show. And they do the calculations. And so I said to the guy, this is a percentage. And as Dr. Harvey just said, greater than 30, people sort of say greater than 30. Is that what you're looking at with obesity? And I asked the guy, does that take into account that maybe my weight has more muscle mass versus fat or adipose tissue? And that's the thing about the BMI. It doesn't really take into account specific body types. So I love the fact that you're using this hip to waist ratio, and then also the waist circumference, or basically measuring around the waist. So it sounds like there are a lot of ways to help people understand if they well, what's the word I want to use? If they can call themselves overweight or obese. And I'm trying to make that in a term, because I think as people talk about losing weight, to get access to some of the care, you have to have that designation by a physician, correct?
That is true, but I think also, we talk about losing weight, but I think a lot of us are shifting and starting to talk about losing fat.
Ah,
Because, the scale could not change if you're losing fat, but also gaining muscle. And I'm not saying, I can see other physicians, pharmacists, the medical community. Please don't say that fat weighs more than muscle, what have you. But, the amount of space, I think is a better way to say it, that
right.
1 pound of fat versus the amount of space that 1 pound of muscle, takes up, looks very different in our bodies. And so, to advocate for yourself to get some of the medical treatment, which includes sometimes a consultation with a dietitian, the actual prescription medication, and in, cases where you have a BMI greater than 30 and you have the comorbid conditions, or you're not able to lose weight, the referral to a bariatric surgeon requires that you get that classification. And yes, to be able to advocate for yourself, you have to know about, also the percent body fat that I may have, the waist circumference or the waist to hip ratio that I
Right,
have.
right. I think that's because you said, we're all about numbers, and I agree. When I was in practice, one thing I used to tell folks is don't pay so much attention to the number. Are your clothes fitting looser? Do you feel like you're
Yes.
toning up? When you see your body in the mirror, does it look a little different to you? But that brings me back to another point. I started with medications, but I should back up a few steps. One of the areas that I struggle with is nutrition.
Mm,
Not that, I love sweets. I will tell you, if you stick it in my
mm.
pantry, I'm going to eat it. And we have an argument at my house about buying stuff, because I'm like, oh, please don't bring it in. It's just too tempting. But I also work out a great deal to counter that. And I think I have a lot of people ask me questions about, are food and exercise still important? Or is this just the way I'm going to be? If I can't stop and give up sweets, like, is it an all or nothing kind of scenario? And the thoughts have really changed about that, right? It's not just making myself not do something any longer, or denying myself something. That's not fair. It's not sustainable.
It's definitely not sustainable. I want to go back to the what you were saying about the sugar. Sugar is addictive. And the problem with the brain is the brain is about neurotransmitters, homeostasis, monitoring hormone levels. And so I need everyone to realize that, and I want you to understand from a scientific standpoint, that if you are addicted to drugs, cocaine, alcohol, sugar, um, the brain can't tell the difference. You know what I'm saying? All it knows is whether or not we have this reward that's going on, or this thing that makes us feel good. And so in the United States particularly, but also worldwide, we are so bombarded with cues to eat certain foods. And they know how to get us. It's like the big red signs, the hot donut sign when we're riding by, or,
Right.
we pay attention to things that are big and bright, and that are flamboyant colors. That's why you'll notice that a lot of the food signs or what have you, they're either red or orange or yellow, something that's going to catch our eye. And so if we're in an environment where we're already addicted to the substances that are in food, because processed food is addictive too. And a lot of people are starting to open the conversation that, one, we're not eating real food, we're eating cheese puffs, chips, or what have you. These are like foods, when you put them in your mouth, your body is already starting to work on digestion and is raising your blood sugar. And so, if you have someone in an environment that they already struggle in, that they're, I can't tell anyone who has obesity or overweight, stop eating, or, stop being around the foods that tempt you. And, history has also shown us that, even the most disciplined person, if you put them in a room with basically their triggers and their cues, 9 times out of 10, it's going to be hard for them to abstain. So you actually have to give them the tools to even plan to fail. There's going to be a day and time that comes where you're going to see a cupcake, and you may have had a stressful day when you see that cupcake, and you may not have had any kind of reward in the past 3 weeks, and that for some reason that cupcake is your reward. Then what? Then what are we going to do? And so now, along with all the advances that, have come through medical science as to the reasons that we have difficulty saying no to certain types of foods, and the reasons why we struggle with losing weight, it's not fair to any person to tell them that, you haven't lost weight because you didn't say no to sugar, or you didn't say no to fat. And, you know, a lot of these diets that are out right now, they set us up to fail
Mm,
because they ask us to take a complete food group, out of our routine diet.
right.
And our brains, the wiring of our brains are designed for things to come a little bit easier for us. Like when you're driving a car, it's automatic. The first time that you go to someone's house, you have to think about every turn and, watch out. But after a while, you're not supposed to do this, but you can daydream. You might even look at the navigation or pick up your phone to see if you got a text. You're not supposed to do that. But you can do so many things while driving versus before you had to pay close attention. It's the same with food. Like right now, if I asked you, what are you going to have for breakfast? I know in the South, it's grits, eggs, bacon, period.
Right.
And so, to make our lives, or to put our lives on autopilot, when you ask certain questions, there's initially already an answer there. And it's the same way with food. What are you going to have for lunch? Most likely the top 10 things I've been eating for the past 30 years for lunch. And to change that rewiring can happen. It's called neuroplasticity. We're human beings. We can change, the signals in our brain, but it's a really difficult process. And it's something that we're just starting to learn how to do now.
So when you're working with patients, then do you usually refer them or help them with some sort of organized, healthy, I won't say meal planning because that's not fair, but to your point, like rewiring. Like if you're trying to teach me that a brownie a day is good, but 9 brownies are bad, and sometimes having an organization or a group of people or a support system in place. Do you refer patients to those kinds of things and as one of the steps in helping them manage their weight?
So I have created my own system. So I do medical weight loss with Dr. K's Family Medicine, and we do know that having a support group, you're more likely to lose more weight. And so, one of the key points that I try to get or the key habits that I try to get my patients to adopt when they join my weight loss program is planning, because it's the most important thing when it comes to weight loss: meal prepping and also journaling your food. There hasn't been extensive research, but there's a lot of research out there that shows that people who actually journal and are honest when they journal,
Yeah,
they lose more weight than people who don't. And so once a week, people who want to join in, they come, we tackle a healthcare discussion on meal prepping, stress reduction, sleep, exercise, what should and shouldn't we be eating. I never tell people they can't have something, because that's the worst thing you could ever
agreed.
do, right? Like right now, don't think about chocolate. That's all you're going to think about for the
Right.
rest of the day.
Exactly.
And we try to encourage one another. What makes me a little bit sad, I must say, is that it's so many people who have access to our meetings, but I can say maybe 5% of the people actually come, because I think people have gotten to the point that they don't think that simple lifestyle changes are meaningful. They may not lead to meaningful weight loss, but they lead to meaningful changes in your body
In your
that we
health.
should also, appreciate besides losing weight.
I agree. I think that's probably one of the things that I heard the most when I was talking with patients is just, can you help me lose weight? Give me a drug. And I go, before we get there, I need you to rethink how you're eating, because when we take the drug away, that kind of thing. So we talked a little bit about food, and it sounds like I think what the audience should hear from that is, you need a support network. You need somebody to sort of help you walk through it. And I think also you need to realize that you're going to make some tough choices, that you have to look at yourself and say, yeah, I ate that bag of chips when I shouldn't have. Um, and how are you going to moderate? The other thing was activity. This is the thing that you talk to some folks that are overweight, and it's just hard for them sometimes to really do extended times of activity. And I don't think a lot of people even understand what that means. People are like, oh, I can't go running. I'm not going to ride a bike. I mean, my knees hurt, those kinds of things. How do you help folks stay active or create some sort of activity plan with your patients?
So typically, I tell everyone to walk, because it's something that you don't need a cardiac clearance to do, and it's something you already did when you came in my office. You walked. However, if a person is wheelchair bound, they also have something called wheelchair exercises on YouTube.
Cool. Okay.
Yes, or for my elderly patients, who don't have access to a pool.
Yeah.
Um, I typically will tell them about the wheelchair exercise. Um, and then other than that, if they can't walk, if they can't do the wheelchair exercise, I just remind them, and I have not found anyone yet, who was bedbound, who could not do my weight loss program. But if they can't do that, I just tell them the most important factor is your diet. If you can't, for whatever reason, exercise, then the diet is the way to go. Now, my people who really want to exercise, they don't have arthritis, they don't have any issues with their joints. I recommend that they try to progressively do something called HIIT training, high intensity interval training,
Yeah.
because it has been shown, one, to help you burn fat a little bit quicker, and two, it increases your exercise tolerance. And so that's kind of my favorite exercise. But lastly, I tell people to do whatever makes them feel good. Zumba, if that makes you feel good. They have video games now where, the video game is an exercise. If that's
Right.
something you can commit to, do that. Just move your body. Just sitting down. I think it's like every hour that you are seated, it increases your risk of heart disease by so many percentage. I'm sorry, I'm not that great with numbers, but I
No.
know it increases your risk of heart disease.
Right.
And so that's why where I love the Fitbits, the what is it, the pedometers that people are wearing on their wrists, and I just try to encourage them to get those 10,000 steps in. You know, we prefer that we have exercise and increased activity, because a lot of people are like, Dr. K, I'm a construction worker. I'm physically active enough. And I let them know that I prefer that you be physically active, but I also want the exercise because exercise is medicine. It's that extra dose of stress that actually improves your cardiac function, helps dilate those arterioles so that you get good blood flow, and also that short amount of stress in the long term decreases inflammation in the body. And we now know that inflammation is the cornerstone of disease. And so if you're active every day, and your heart rate is 65 or 70, or you have that tolerance, I need you to do a little bit more within that 1 hour period, because that extra that you do in that 1 hour is actually your medicine.
It's so funny you say that. I used to tell folks, I have a lot of folks that used to be wait staff servers, and they would say, I'm on my feet all day long and I'm activity. I go, yeah. I said, here's a sad thing. I need you to go one above that versus the person that sits at a
Yes.
desk all day. And I go, I don't mean to punish you, but we need to go just like a little, like one level above. So I hear food, I hear exercise, but I will tell you, and I think you probably know more than anybody, the shift to the discussion about drugs for
It's been a long time coming,
it
and we
has been.
need to have it.
It has been, and there have been some new drugs, but before we get there, I was doing some reading, and actually, your talk in November prompted me to like go out and do some reading and like sort of see things. And I was trying to figure out how are these drugs different than what we used in the past? Like what makes these drugs so good at what they do? And what I was reading, it surprised the heck out of me. I grew up with the mentality of what you just talked about. If I eat better and work out, I should lose weight. I wasn't necessarily born with a thin frame, but I wasn't born with a large frame either. So I can, I'm in that process. But then I have other friends like my brother. My brother could eat an entire pig on his own and still be as slender as anything out there. I'm reading now that there's a possibility that folks who gain weight easily or can't lose weight, it's not all about the food they take or the exercise level, that there may be some, I don't know how to say it, some parts missing here or there, and we're trying to figure out how to make that work in the body with those drugs. Is that a fair way to describe it?
That's a fair way to describe it. Especially the, what is it, Contrave, the GLP-1s, and even phentermine to an extent. That's how it works. It basically, well, phentermine mostly helps work by making you feel fuller, and it also activates the part of the hypothalamus that tells you not to eat. But the GLP-1s, they are kind of tapping into our hormones. So GLP-1 is a hormone produced by the small intestines, and it basically slows the gastric emptying in the stomach. So it makes food stay in the stomach longer, and it makes you feel fuller longer. But it also activates a part of the brain that tells you that you don't need to eat as much. And then it also activates a part of your brain that increases your metabolism. And so, once upon a time, like you said, we believed that obesity was just simply certain people ate more and worked out less. Now we know that obesity may actually be generated by hormones. And and even further, we also know that the flora in your gut may also drive whether or not you have a little bit more adipose tissue or a little less adipose tissue than other people. And so I want to also circle back and say that our environment has shifted, the hormonal
True.
signals in our body, as well as the food has
That we're
shifted the
eating.
hormonal
Yeah.
signal. The high fructose corn syrup, because it bypasses insulin, which is really important when it comes to weight loss and weight gain. It causes us to eat more. And because of some of the foods that we eat that are full of carbohydrates, or um, full of different preservatives, but more so the sugar and the carbohydrates, it causes something called insulin spikes. And so the problem with the insulin spike, we get this big flux of insulin, which tells our body to build and to store fat. And supposedly the insulin is supposed to go to our brain and say, okay, we got a sugar spike here. You
Right.
can stop eating now. But because a lot of us have become insulin resistant, because we keep getting that high spike of glucose, and we keep sending up that message that you need to build, you need to build, you need to build. because of that, we eventually become insulin resistant. So the liver stops listening to that increase in insulin, and it continues to make glucagon, which continues to pour out sugar, which continues to create inflammation throughout our body. It's longer past, but this is the result: increase in sugar, increase in stickiness of our blood vessels, increase in with the inflammation, more difficulty with weight loss. And our brain, the insulin is supposed to say stop eating, but because the brain is insulin resistant, it doesn't get the message. Now is the time to cut down. Somehow or another, because of this GLP-1, because of the efficiency with how the pancreas puts out insulin, our bodies are getting the signal that this is enough food. You don't need to eat anymore.
Right.
And our brain is also getting that signal, most importantly.
So, for those people listening in, you just got an entire metabolic lecture on thinking about the way sugar runs through the body. But you said something really important there. GLP-1, and I want to really define this real quick. This is the Ozempic, semaglutide, Wegovy, Victoza, all those drugs that you're hearing people talk about getting a hold of. Those are GLP-1s.
Yes, they are. I don't want to tout it as the miracle drug because that's what everyone is calling it. And I'm sorry, I have a number of patients that are on Ozempic. I used to place a lot of patients on Victoza before the craze with Ozempic because, it's older.
It is.
And, when I put my patients on Victoza versus Saxenda because no one could afford Saxenda.
Yeah. So people out there in the community may know this. Victoza and Saxenda are actually the same drug. Ozempic and Wegovy are actually the same drug, but the dosing is a little different. And so, but now Victoza and Ozempic are indicated for diabetes, right?
Yes.
For people who have a diagnosis, not just folks that are a little overweight with diabetes, but are diabetes only. And then they may have a little weight because they have diabetes. Is that?
So Victoza is approved for diabetes, but Saxenda actually have FDA approval for weight loss.
Got
But
it.
like you said, it was kind of a trick of the company. I'm calling you out.
Yeah.
It's the same exact drug. They just
It
got
is.
to market it differently and make some extra coins off of it. I'm calling you out, Big
Yep. And
Pharma.
Ozempic did the exact same thing with their drug too, the semaglutide that everybody's trying to get their hands on.
Yes.
You bring up this class of drugs, and I was reading once again, the American Gastroenterology, which is basically the stomach experts, came out with some research and said, you know what, these are the 4 drugs we like, or 4 classes we like, and the GLP-1s were in that group. But you just said this, Ozempic outperformed Victoza. It had more impact on weight loss. That's what they said, correct?
That's exactly correct. I think a big problem with the Victoza is you have to take it every day. And it seems that people are having a few more of the side effects. The number one, and more people are likely to drop out of a study. Well, from the studies I read, more people are more likely to discontinue the Victoza because of side effects. And the number one is nausea and
Right.
vomiting. And so even when you titrate them up slowly, a lot of times they'll still come up with that. But when we go, I don't know what it is about the long term or the longer half-life of the Wegovy or semaglutide versus the liraglutide. I know from my experience, the decrease in side effect, the ease of use, it makes patients more adherent, and therefore they see the benefit. And once they start seeing the drop in weight, they don't want to stop.
Yeah. And
I mean, even with me telling patients, you might get cancer. We don't know yet. We have only seen it in animals.
Right.
But there's a small risk that there is cancer linked to this drug. And I must also say that just shows you, if people are willing to inherit the side effects of a medication, and one of the potential risks is cancer from taking a drug, it shows you how committed people are, or how determined, or how much they desire to lose this weight. So it can't be simply, we're not losing weight because we're not following a certain diet plan.
Right. It's interesting because the GLP-1s give the body back a protein that's missing from the stomach in a lot of folks. And people always ask, why does it cause nausea and vomiting? Well, people may not know this, but that protein actually comes from a different animal, not humans. It comes from the Gila monster. So our body for the first couple of weeks is saying to itself, what the heck? You're giving me something weird here. And it makes the stomach react. But your point about moving the dose up slowly for these drugs, they tend to have pretty good impact. And Ozempic, gosh, what was it, at 18% weight loss or something like that? Like people lost 18%?
Yep. So it depends on which study you read, but it's between 16 to 18% weight loss that we're seeing with Ozempic. And this almost rivals bariatric surgery because we see about 25 to 30% weight loss with bariatric surgery. So yeah, and the older drugs like everyone's favorite drug back in the day was Adipex,
Yeah.
or phentermine. It's 5% with that one, and then the phentermine to pyramid combination is only 8 to 10% weight loss with that one. So if you get a person to losing almost 20% of their body weight versus never seeing that before with diet and exercise. So diet and exercise, typically you get 3%
Right.
loss of body weight. And
so if you did your diet and exercise, lost your 3 to 5%, and then got to the point where you're on Ozempic, or you have a potential of like 20 to 25% of your weight being reduced.
And you tell anyone who has struggled with their weight that they're gonna hop on.
That's a huge deal. Interesting you bring that up though, because talking about the older drugs, the other thing about those, they were stimulants, right? They sort of made your metabolism increase.
Yep.
And unfortunately, you have to come off them because you can't stay on them for long periods of time in many states. So this drug though when you talk about that GLP-1s, they're not controlled substances. The older drugs like the phentermine was a controlled substance, or is a controlled substance. So the GLP-1s have the potential for you to stay on them longer period of time, correct? Do we know when we can stop them now, or can we continue them? I know diabetes, if you have diabetes, you can continue on, but let's say we're using it just for weight loss. How long can you stay on them?
As long as you need to, but you've seen, I think most people have seen all of the commercials that we're getting about Wegovy, Ozempic.
Yeah.
They're actually asking you to stay on it lifelong. I mean, they're not coming out and saying the word lifelong,
right.
But at the end they say, if you stop this medicine, you will regain all your weight. And so, I think it is our duty, while people are on this medication. I tell my patients, this is a tool. That's all I want it to be for you, a tool so that you can adopt these specific habits and these specific routines. And yes, if you decide, or when you decide to come off this medicine because your insurance stopped paying for it, if they pay for it,
right,
or you just don't, you don't want the side effects, or you just don't want to take a drug for the rest of your life, you're going to gain some of the weight back. But what I want to not happen for you is for you to gain all of your weight back.
Right. No, I think that's a really great point. I read an article the other day. Again, I've been, ever since November, you've put me on this pathway to read about this phenomenon of these drugs, because I'm amazed that here's a drug that was created for diabetes to manage our sugars, to figure out how to keep them controlled, has morphed into this drug, to your point earlier, that reduces inflammation in our body, turns our brain off, so to speak, and makes our stomach tell us, you're full, put the sandwich down. And it's like, I'm just amazed by this technology, this discovery. But I read that for people that have been on this for a period of time, some people actually were able to stop and maintain their weight loss, and then other people weren't. So again, it's person by person, discussion by discussion. So that brings me, you talked about the old drugs. I have to admit, I want to talk about this drug too, because in my reading, I came up with the new drug that just got approved for diabetes care, but people are going bonkers for this drug for weight loss. Was it called Mounjaro? Did I do that correctly?
Mounjaro, dun, 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 Mounjaro. Now, everyone is talking about it now. I actually was so excited about it when I first heard about it, and the pharmacy reps have already visited my office. I actually bought stock, but because I talk about obesity and I talk about drugs, someone said, you're going to have to do a disclosure in your talk. So I sold my stock for Mounjaro, but I know it's gonna take Eli Lilly to the next level.
That's the maker of this. So what makes Manjaro different than Ozempic or Victoza? Because they're kind of in the same area, but they're not identical. They're not the same class.
Yeah, so back to those hormones we were talking
Oh,
about,
okay.
but it has an additional hormone. It's called a GIP agonist, glucose dependent, insulinotropic peptide in it. And you know what's
That's easy
weird?
for you to say.
What's weird, GIP alone is supposed to be an obesogenic agent, something that makes you gain weight.
Oh,
However, when it's paired with GLP-1, together they have this synergistic effect, that makes GLP-1 work even better. So, I told you it makes food stay in your stomach longer. It delays gastric emptying, so you're fuller longer. It tells your brain, hey, we don't need to eat. It's enough right here for what we need. And then also it helps when the pancreas secretes insulin instead of getting that big spike that after you eat and after the insulin go down, you want to eat everything, you're ravenous. It slowly and steadily raises your insulin instead of getting that big spike that we don't want to get from the certain foods that we eat.
so is it fair to say that these drugs are kind of retraining our body to work the best they can?
It's training our body to work in the way that it was designed to work.
I see. I see.
Yeah.
So I get this goes back to what you talked about earlier. That means that some folks that just can't seem to lose the weight don't have enough GIP or GLP, where other people who can eat anything they want not lose. Is it fair to say we're replacing sort of what their body doesn't have for them right now? Or is it as simple as that?
No, it's not that simple because the problem with obesity and why some people are thinner than others is so complex that it's not simply reduced to one hormone.
Got it.
Um, the best example of this is people were once saying that if we're leptin resistant, why can't we just make a leptin like medicine to cause us to lose weight? So they tried to come up with a substance that's like that. It didn't work. And then, another problem with obesity is the amount of ghrelin that some people secrete. Some people secrete a little bit more than others. People call it when they have bariatric surgery, ghrelin-nectomy, because it's we're cutting off the part of the hormone that's the part of the stomach that secretes the hormone that makes us hungry. And so there's something called NEAT. God, and I'm so sorry, I cannot remember, but NEAT, look up NEAT in dietetics, but it basically says that our metabolisms are different. I forget it, but our metabolisms are different for whatever reason. So it's, some people just have and I can't even say that. The NEAT explains why some people burn more fat than others, but people who have obesity also have a higher metabolism. It's just not a balance in the amount of um I guess the types of food to cap off the amount that they burn, and so they store a little bit more fat. So, I'm sorry, but I cannot
That's
reduce it to
okay.
just GLP-1 or one thing. It's a lot of things.
But what I'm hearing you say though is it's no longer just about I didn't exercise enough or I ate too much. There's a lot going on in our bodies that
Yes,
we're discovering these drugs go in there and they make it better. I don't know how to say that, but they
that
make
is
our
true.
bodies work up. They take the part that's not working well and they try to make it really work.
Yep.
You said something earlier that I want to circle back to now. These drugs, the Monjarno and the Victoza, Ozempic, even when you look at Contrave, the drug that has bupropion and shucks, naltrexone in it, these are expensive. I mean,
Yep.
we're not talking. As I sit here and as I sit here and we do this, I'm like, all these people are rushing out to get this, and everybody wants it. But at the same point in time, there's a bit of sticker shock. If I'm not mistaken, if you're paying out of pocket, a month's supply could run you $900 to over $1,000 of
Yep.
these. That's okay? So how do you help your patients get these products if they qualify and they're candidates and all that great stuff? I mean, I don't think this should be just random. Everybody just grabs it because you're overweight. I mean, I think your primary care physician needs to guide it. but I also see the benefit in this, and I don't want people not to have it because they can't afford it. That just seems counterintuitive to me. Because
Yeah,
I was
I
just saying,
w-
because being obese causes a lot of health problems. It seems like if we give a medication that helps people lose weight, we actually keep people away from diabetes, heart attacks, strokes.
yes, yes,
To invest in the drug makes sense
preach.
to me, right? I mean, so how do we help people get to these drugs that need them to stay healthy?
I want to repeat that drugs are a tool, you guys. I want you still to employ lifestyle
Got it.
changes, but when it's time and you see that this is an option for you, rely heavily on samples, and I don't mind begging. I don't mind asking the pharmacy reps for a little bit extra, but also, you know, most, if not all of these big pharmaceutical companies have a patient assistance program.
Okay.
And so you have to look heavily with that small writing on their website. And typically there's a form that you can fill out. You have to disclose how much money you're making, why you need this medication. And a lot of times they will oblige you for a few months with the prescription. So we can go that route. Two, if you have metabolic syndrome, pre-diabetes, which most of us already do have pre-diabetes and we just don't know it. There's a HOMA score that your doctor can put into a calculation, but it's a calculator, but it's based off your insulin level, excuse me, and your glucose level, and it can basically tell the risk that you have of contracting diabetes, or how insulin resistant you are, for the correct term. And once we secure those diagnoses, a lot of my patients have been able to get Ozempic because they are insulin resistant or pre-diabetic. Of course, we may have to do something called a prior authorization, and that's just another way of us begging, us
Right.
telling the insurance company this could be life-saving. If you put this patient on this medication, it may reverse her cholesterol or his cholesterol, his blood pressure, his diabetes. And so that's how I've been able to secure it. But we need the help of the community. The power is within the people. If they can talk to their representatives, get weight treatment approved by insurance companies, and get insurance companies, Medicare, Medicaid, to also place the drugs that help with weight loss on their formulary. That's the only way that we're going to secure equity amongst people who have obesity and overweight, to everyone else who may not, need those drugs because they don't have the morbidities, or they don't struggle with the disease.
Got it. It's interesting. You mentioned patient assistance programs, vouchers. The other thing I talk about is sometimes there are actually coupons out there that you can use if you're
Yes.
cash pay. And then there are a couple of apps for the audience that you can look things up to get an idea of price. I think one of the areas that I talk about a lot, and you said this earlier about prior authorizations, don't expect to walk in, be told that, hey, this is where you are, and go, I'd like Ozempic, and expect that
Yes.
in that day you're going to be able to get it, because
Hmm.
it'll take a little bit of time to get that established. We've covered a lot. We've talked about background and eating healthy and how we should stay active, and here's some new drugs and what they're doing to our bodies and making us actually be more efficient in the way we handle nutrients. If you had to sum up everything in three pearls for our listening audience, what three things would you want them to take away from our conversation today? Three short pearls to make them go, okay, I know what I need to do now. I know how to sort of tackle my weight issue.
The first thing is, one, the all of the power, lies within you, as being an advocate for your own health care. What your weight loss journey or your health journey has been.
Fair.
And I still want you to continue to do the good work that you're already doing: meal prepping, eating the best diet that you can with the life that you have, and challenging yourself and taking it a step further, but also educating yourself on all of the different weight loss medications that are on the market, finding out what resources that are available to you, finding out if if you want to have bariatric surgery, what are the risks? Do you qualify? And also educating other people that obesity is a disease. And yes, our environments have led us to become obese, but there's a place for medical science to treat this pandemic that we're currently in, the pandemic of obesity.
Yeah, I think that's a great point. I failed to mention when I first came on, but I wanted to repeat. I think over 40% of Americans are classified as being obese.
That is true. And I want to say, I don't want anyone to ever think that I can reduce obesity down to just, diet, whether or not you're exercising, this one particular hormone or genes or anything. It's so many things that are working against us in this current environment. And at the rate that people are becoming obese or having obesity, we have to become innovative and what's the word? I guess innovative is the best word in how we approach this disease. We have tried, I think about all the different diet plans that have come and gone over the years. If that was the only solution and the solution, then we wouldn't continue to see this uptick in the rate of obesity now.
Yeah, I agree with you wholeheartedly. I think, and I think for those listening from the community, you're thinking about this and what do I do? The first step, talk to your primary care provider, figure
Yep.
out what plan works for you, and then start the process. But I think Dr. Harvey nailed it on the head. No matter what we tell you is right or wrong, when you leave the office, your journey kind of begins with you
Yeah.
and your decision. Dr. Harvey, thank you so much.
Well,
As
thank
always,
you.
I love having this conversation with you because you make me think and you put things in perspective and you remind me of the fact that managing weight is not just simply let's not eat as much and work out more.
Yep.
There's so many other factors. Guys, listening in, I hope you enjoyed this talk. I hope you walked away with some knowledge. Tune in next month. We're going to be talking about the HPV vaccine as well as how that deals with prevention of cancer. Until then, my name is Dr. Tim Brown. You've been listening to Pharmcast for the Community, sponsored by the University of Georgia's College of Pharmacy. As always, for another month, stay healthy. I'll see you then.